Welcome to tonight's webinar. I would like to introduce our moderator for tonight, Dr. Dawn Laporte, President of Ruth Jackson Orthopedic Society.
Thank you, Deborah. Good evening and welcome. Thank you all for joining this important webinar on implicit bias in orthopedic surgery and for your many thoughtful submitted questions. It's an honor to introduce our outstanding panel of speakers for this evening. Dr. Linda Suleiman is an assistant professor of orthopedic surgery specializing in hip and knee arthroplasty at Northwestern University. She also serves as Assistant Dean of Medical Education and Director of Diversity and Inclusion for Graduate Medical Education at Northwestern. Dr. Erica Taylor is a hand and upper extremity surgeon at Duke University. She serves as Chief of Surgery and Medical Director of Orthopedic Surgery at Duke Raleigh Hospital, as well as Vice Chair of Diversity and Inclusion in the Department of Orthopedic Surgery. She also was recently selected to serve as the inaugural Associate Chief Medical Officer for Diversity, Equity, and Inclusion at Duke Health. Dr. Monica Payeras is an assistant professor of pediatric orthopedic surgery at the Nicholas Children's Hospital in Miami. She serves on the board of the American Association of Latino Orthopedic Surgeons. All of these outstanding women are dedicated mentors and are committed to increasing diversity and inclusion in orthopedic surgery. It's my pleasure to turn the program over to Dr. Linda Suleiman to tell you more about the topic and the structure for tonight. Thank you all.
Thank you so much. Can everyone hear me? Hello, everyone. Good evening. My name is Linda Suleiman, and I'm an orthopedic surgeon here at Northwestern. I'd like to take the time to really thank Dr. Dawn Laporte for the invitation for myself, Dr. Payeras, and Dr. Taylor to use the RJOS platform to talk about bias, more specifically implicit bias. And 2020 has really pushed these conversations forward. And I know this can be an uncomfortable topic for most, so I want to make sure that we have enough time at the end for discussion. This will be outlined for this evening. Each of us will spend about 10 to 15 minutes. I will start with talking a little bit about the case for implicit bias education in orthopedics. Dr. Payeras will continue with some real case examples of bias in action. And Dr. Taylor will conclude our session with strategies and solutions. At the end of the session, we'll have a question and answer period. You may submit questions through the chat here live, but we also have some submitted questions that were submitted ahead of time. So why are we here today? Every year, I see the number of medical students that are women and underrepresented minorities entering the field that are well below the growth and trajectory of other specialty groups. Then I'm reminded of the bias that these groups experience while training. However, the bias begins when they enter our rotations, when they're applying to orthopedics. And the quotes I've shared on my slide here today are just a few of the bias statements I've read from hundreds of residency and fellowship applications, letters of recommendations just this year alone. For example, he was one of the few students that I did not have to teach how to communicate in real English. This is from an application of a Latino male. He was always well-groomed and professional. I read this from 3 applications from Black males, letters of recommendation. And finally, I hope she can become more comfortable with the excellent physician and human being that she truly is, so she can relax, smile a bit more, and become more relatable to all people in her environment. Now, these letter writers have been identified by these students, by these residents, as those who are supporting them. So although these letter writers intended no harm, the bias in these letters distracts from the applicant's success and strengths and focuses on stereotype. Diversity, equity, and inclusion in orthopedics is a progressive discussion, and we as orthopedic surgeons really must understand our diverse community in which we serve. So there are a number of areas that really must be addressed to combat these structural inequities. And a significant missing link is really equipping orthopedic surgeons with the ability to assess work environments, really strategize effective interventions, and accurately measure the impact of these change initiatives. Ortho is not diverse. We do not have the female representation, nor do we have the representation of people of color in our workforce. in our society leadership, our editorial boards for major journals, our chairs and our program directors. No one looks like me. So this type of representation has not changed drastically for decades, nor will it change without a culture shift. And this culture shift will not occur with the handful of women and people of color that we currently have in our specialty. The culture change occurs with the majority, and that majority is with our white male colleagues. And it's with these additional skills that I believe our leaders can be empowered to address these deep-rooted issues behind cultural transformation in these challenging times. We are all here today as colleagues, as residents, as medical students, to work towards achieving what I call equitable responsibility for all patients and colleagues from underrepresented groups. It's simply just not enough to just focus on intentional discrimination, but to really work towards the bias and judgment and the behavior that results from these cognitive processes or the implicit bias. One of my favorite quotes is from RJOS, from his book, Everyday Bias. Categorizing people without realizing it is as natural as breathing and allows us to navigate the world. Bias is so common, it's second nature, and we don't realize it until we're doing it. So if I asked every single person on this webinar how many times you blinked today, it would be a hard guess, but that's how frequent these instances occur. So at which age do we form these implicit biases? So I want to share some historical reference to know where we started. So in the 1940s, psychologists Kenneth and Mamie Clark here, where I live in Chicago, designed and conducted a series of experiments known colloquially as the doll tests to study the psychological effects of segregation on Black children. So Drs. Clark's used 4 dolls, identical except for color, to test children's racial perceptions. Their subjects, children between the ages of 3 to 7, were asked to identify both the race of the doll and which color doll they prefer. And a majority of the children preferred the white doll and assigned these positive characteristics to it. So the Clarks concluded that it was prejudice, discrimination, and segregation that created this feeling of inferiority among Black children and damaged their self-esteem. Now, many people might say, Linda, this isn't the 1940s. We're living in a different time, but time and time again, we are seeing the exact same patterns of discrimination in medicine. So we're still seeing Black and brown patients at a disadvantage. Just this weekend, we read the traumatic experience of Dr. Denner, a Black female program director at Tulane, go through a traumatic series of microaggressions. So to be clear, nothing has changed between the doll test in 1940 and 2021. In fact, the exact same experiment was conducted that Dr. Clark's conducted was redone in children in 2012 with the exact same results. So implicit bias begins at a very young age. It's a pro-white bias that has been observed in children as young as age 3. And it's because of these repeated reinforcements of societal stereotypes. This is just another example. I have a 17-month-old daughter. I was sent books by her cousin. So when she's older, she's got these homework helpers. And I immediately just flipping through the book, I see this, a young Black girl associated with angry, young Black male associated with sad, young white girl associated with happy, and the young white boy associated with proud. So it's the smallest pictures in books that send that unconscious message that when we aren't even thinking about it. So implicit bias is this unconscious preference for a specific social group that can have adverse consequences. And implicit bias really refers to the biases we carry beneath the conscious awareness that alters our behavior. So it includes things like tribalism, stereotypes, sexism, racism, prejudice, and discrimination. So the implicit association test is just one tool that has been commonly used and you may have taken it. It's been based on race. It's not limited to race. There's characteristics such as gender, age, sexual orientation, gender identity. And the IAT is really designed to elicit and collect your automatically activated and really often unintentional biases. And these biases affect the hiring and promotion of staff, clinicians, and faculty that really can impact patient care. So know that these preferences do not make you a bad person. It's the use of this test is to really recognize that our response is really based on stereotype, with hopes that knowing your own stereotype would implore you to consciously adjust your response. And at the leadership level, you want to evaluate your own potential unknown biases, as well as address the programmatic structures that perpetuate these disparities. So addressing our implicit bias is never easy. It's really through this personal reflection and implementation of specific anti-racist measures that really can create a culture which helps our healthcare system support the societal change. We have the responsibility to really mitigate the effect of implicit bias in this organizational decision-making and addressing our own unconscious bias and how that plays a role in hiring and promotion is a good first step. We want to educate and train ourselves to mitigate any adverse impacts of bias, such as disparities in healthcare outcomes. So now, how do we mitigate these biases? We start with introspection. You have to be open to the fact that you have bias, whether conscious or unconscious. So if you're that person that says, I'm colorblind, I don't see color, I don't see gender, you likely have the most deep-rooted biases, and quite frankly, you're in denial. So explore and really identify your own prejudices by taking the IAT or through other areas of self-analysis. Next is really recognizing that our response is based on stereotype and consciously adjusting our response. And this takes work. When interacting with colleagues or patients, you see the person as an individual rather than that stereotype. So learn more about who they are, about their own personal experiences. Increase opportunities to interact with different groups and expand one's network of friends and colleagues. So if you're sitting on a committee or an editorial board or board of directors, look around the room. If everyone looks like you, you're missing out on opportunity for valuable thought leaders. That allows for more perspective taking. And to support a culture of inclusion, we really must, as a specialty, identify what I call our group's blind spots. So this can be accomplished through an equity lens tool, which is used to really to improve planning, decision-making, resource allocation, leading to more racially equitable policies and programs. And the hardest part for us as orthopedic surgeons is always to slow down. So I implore all of you to pause and reflect on your potential biases before interacting with people of certain groups to really reduce these reflexive reactions. I wanted to also share and highlight where we are compared to other specialties according to the ACGME data. So we've made improvements with increasing female representation, but we still have a considerable amount of work to do with race and ethnicity. And this is a common trend that we see when we talk about diversity efforts and are pushed with gender, and that tends to be the more comfortable pathway and approach. So I would implore you, when you think of diversity in orthopedics, we can't just talk about women being the only addition. So these efforts start with recruitment and changing to a more holistic approach. So what are the admissions and recruitment practices that may help us bridge this gap? So the holistic review is the first step, it's a good first step. The AAMC has really promoted a holistic review in the admission process. And in doing so, it challenges us to assess each applicant's background, experiences, attributes, and academic metrics. So in addition, we should assess what I call distance traveled, or how far a student has come in light of discrimination or a lack of resources to get to where they are today. A process of holistic review allows us to more broadly assess one's potential to really contribute, even if he or she has not had the privilege of attaining historical metrics. Next is a diversity pulse check. It's a very simple 10-point check to understand whether your organization is really ready to have these conversations to leverage diversity and fully engage all of your employees and staff. And to be an ally is to take on the struggle as your own and transfer the benefits of your privilege to those who lack it. So take the chance to really amplify voices of the oppressed before your own and really acknowledge that even though you feel pain, the conversation is not about you. Being an ally is hard work. Many, what I call would-be allies, fear that making a mistake could have them labeled as a racist or a sexist or a homophobe. But as an ally, you're also affected by this system. Your patients are affected by this system. This means that as an ally, there's much to learn and then there's much to unlearn. And mistakes are expected and they're going to happen. You need to own this as fact and should be willing to embrace the daily work of doing better. So while mistakes are expected, what's the best way to go about really resolving them? So one of my most favorite analogies that you probably could pick up in any orthopedic scenario is imagine that your privilege is a heavy boot that keeps you from feeling when you're stepping on someone's feet or they're stepping on yours. While women and underrepresented minorities in orthopedics only have sandals. So if someone says, ouch, you're stepping on my toes, how do you react? So these are some of the most common problematic responses that I've seen. First is centering yourself. Well, I can't believe you think I'm a toe stepper. I'm a good person. Denial that others' experiences are different from your own. Well, I don't mind when people step on my toes. Derailing the conversation entirely. Well, some people don't even have toes. Why aren't we talking about them instead? Refusal to center the impacted. All toes matter. Tone policing. Well, I'd move my foot if you'd ask me more nicely. Denial that the problem is even fixable. Well, toes getting stepped on, it's a fact of life. You'll be better off when you accept that. Victim blaming. You shouldn't have been walking around people with boots, and withdrawing completely. Well, I thought you wanted my help. I guess I'll just go home. So change your response to mitigating these common mistakes to changing the conversation and changing your response. Center the impacted. Are you okay? Listen to their response and learn. Apologize for the impact, even though you didn't intend it. A simple, I'm sorry. Stop in the instance, move your foot. Stop the pattern. Be careful where you step in the future. Because when it comes to oppression, we want to actually change the footwear. So we must always look deeper, get uncomfortable to root out bias in orthopedics, because we must create an inclusive culture for diversity and equity to not just survive, but to thrive. And we are all here so far, and we are so far from that. So recognize diversity and inclusion is good for all people. It's not about giving opportunities to people who are undeserving or denying opportunities for yourself. It's about identifying those who are deserving through non-traditional means. Thank you. I've shared my email here today if you have any questions for me in the future, and I'll turn it over to Dr. Payeris.
Great, that was excellent. I'm going to share my screen now. There we go. Can you guys see it?
Yes.
Excellent. You guys can hear me well. Great. So first of all, thank you so much for the invitation, Dr. Laporte, and my panelists here. It's an honor to be here amongst you awesome and very successful ladies and talking about something that hits us so deeply. So thank you for having me here, and I will continue in some of the things that Dr. Solomon already mentioned. And we're gonna go into a little bit more of examples and types of implicit bias and how this affects how we take care of patients in medicine and in orthopedics. So this is a busy slide for many reasons, okay? So we know that there's disparities in the quality of care they receive by minorities, and this has been reported for decades across multiple different medical conditions, types of care, including institutions and including our own biases. Recently, as the 1980s, African-American surgical patients were more likely than Caucasians to be treated by trainees or residents rather than by the attending. Non-white patients receive fewer cardiovascular interventions. African-American women are more likely to die after being diagnosed with breast cancer. Patients of color are more likely to be blamed for being passive in their healthcare. Even within healthcare professionals, they tended to associate men with career and surgery and women more with family and family medicine. And we know there is only 6% of women in orthopedics, okay? And that is because there's many factors that contribute to female or medical students being reluctant to pursue this because either limited exposure, negative perception of the field, lack of female mentors, lack or barriers to promotion, and a lot of other things that you guys have already mentioned and that we're very familiar with. The important part and the main reason for this, and there's a ton of other studies within healthcare that show this, okay? And what we're trying to do tonight is we want to bring awareness, because that's the first step. If we are aware of the existence of these implicit biases, this is going to help us minimize what the potential downstream effects of what that can do and how that can help us care for our patients. So another one of our colleagues, Dr. Humbert, had a nice little article, and this is more specifically talking about orthopedic surgery. And within orthopedic surgery, it's a little bit unique because we do procedures that are most of the time elective, right? So while we are offering great value and great care to our patients, in of itself, we can actually have a risk of having our own biases affect our care. So for instance, we are sometimes sort of choosing our patients as well. So if we say patients that have a higher risk, for example, a patient that's obese, they may not be treated as an individual, and we sort of will group them together with all patients that are obese and maybe have higher complications, and we may be trying to not take care of those patients, okay? And there is a moral hazard there. So if we are approaching our patients with biases, whether they're conscious or unconscious, we may actually misdiagnose. This is going to contribute to healthcare disparities, and eventually it will lead to failure of us to fulfill our obligations as healthcare givers. There's a recent article talking about total knee replacement and the racial differences in pain. So African Americans were found to have worse preoperative and postoperative pain and function with knee arthroplasty as compared to Caucasians. But one of the, and we knew a lot of this, there's a lot of studies that show that African Americans are considered to feel less pain. Why? They are human just like you and me and anybody else is different colors, right? But this, again, these are cultural things that have been passed on even within the medical profession. The interesting part of this is that this group concluded that race and socioeconomic and psychological status were not really even taken into consideration. And these studies were assessing knee arthroplasty outcomes. And this is an important gap in the racial disparities literature. So it's not just race and gender. We want to talk about implicit bias, right? So age, body habitus, color, disabilities, right? Socioeconomic status, immigration status, mental health, their race and ethnicity, your sexual orientation. There's a lot of different things that can affect our clinical decision as healthcare professionals. And you have to, and this comes not just from making it through the training, but also how we're caring for our patients when we are attending. So how do I know if I'm biased? And I know Dr. Seligman already mentioned some of this. The implicit association test, which is a validated tool to measure implicit biases. So it's a series of publicly available computer tests that were developed at Harvard, and there's a link there. What they do is they have the participants associated with words and images, and it sort of times your automatic association between your concepts. And they are doing this basically it's designed to help us prompt our self-reflection. It's designed to help promote discussion and awareness of your own personal biases, and not really as a metric for measuring implicit bias or any other curricular outcomes. And there's a number of different ones that you can take. And there's different types of biases, right? We talk about conformity bias. So for instance, if this is based on a study that's been around for many years, and it relates to a bias that's caused by group pressure or peer pressure. So in the study, if you have one individual is blinded that the other people in the group were told to give the wrong answer, and if they already know that everybody else in the group has this answer, even though it's different from the one that he thinks is right, 75% of the time, that individual is going to decide to scrap their own opinion and favor the group's opinion. So you can only imagine how that can affect. So let's say you have a panel and you're talking about a candidate coming in for medical school, and everybody said, the majority already said, it's a bad candidate, even though you think differently. It's going to make you feel that if the majority of the group is already leaning towards or away from a certain decision, they may tend to go along with the group and not voice their own opinions. Okay. Beauty bias, which is the view that we tend to think that the most handsome individual will be the most successful, right? And this, again, these physical attributes do play a role in our biases. You know that 60% of CEOs in the US are over 6 foot tall, even though only 50% of the population are over 6 foot tall. This will clearly make, be something that I would never be able to do. I'm only 5 foot tall, so definitely not going to be a CEO of anything, right? So affinity bias, and it occurs when when we have an affinity towards somebody or someone, maybe that they attended the same college or they're from the same town that you're in, or for the same country, they remind us of somebody that you know, and so they're going to be speaking in much higher terms from that particular individual. Similarly, the halo effect. So if you like one great thing about that person, you let that halo glow, and anything else that's about opinions about everything else around that person is good, as opposed to the horns effect, which is the direct opposite. You saw one thing, and then everything else is going to be clouded by that opinion about that one thing of that patient. Similarity bias, again, we want to surround ourselves with people that are similar to us, right? So we tend to work more with people that are like us. Attribution bias, this is when people are constantly making attributions regarding the cause of their own and others' behaviors. So for instance, if we do something well, we tend to think that it's because of our own merit and personality, but when we do something badly, we tend to believe that others are failing us and it's due to external factors. But when it comes to other people, we think the opposite. So if somebody's doing well, it's because they're lucky, and if they're doing bad, it's because we think it's their personality or their bad behavior. All right. Confirmation bias. This is one that we have to be very careful. And this when we start making judgment about other people, we subconsciously look for evidence to back our own opinions, right? Because we think that we want to believe that we're right, and we want to make sure that we made the right assessment about that person or that patient. Okay. So let's talk a little bit more about a particular example. So LB is a 19-year-old obese Hispanic woman who comes in with chronic knee problems for the third opinion. Okay. She also happens to be a Division I athlete. She's very well versed in exercising and dieting and all those things to take care of herself. So she comes in because her main issues are her knee pains. She's had numerous patellar subluxations. She has extensive non-operative treatment. And first thing she comes in and she gets welcomed by the MA. They get her vitals. She has normal BP, but her BMI is 35. The comment from the MA taking the vital says, "I'm surprised that your heart rate and your blood pressure are so normal, even a little bit low given your size." So at that time, the patient is like, well, I'm going to not say anything. I'm going to just wait for the physician. No big deal. I've heard this before. Physician comes in, takes the history, starts talking to her, specifically focusing on her weight and her BMI and how these are big contributors to her chronic knee problems. The physician goes into extensive detail about the importance of regular exercising, cutting back on junk food, and all those things. They recommend her to see a dietitian and to work out more and give her a referral to do physical therapy. And the patient said, well, I've already done extensive. I really want to proceed with surgical intervention. I've gone to 2 other orthopedic surgeons. They don't want to operate. I feel like this is what I need to do to get better. And the physician said, well, okay, let's see how it goes. We'll start from now. Let's see how it goes once you're with me. Patient omits to comment on other medical issues and sort of leaves the visit sort of feeling unheard, but is willing to give it another chance. She comes back 3 months later, has gained some weight, still having some issues. She's now complaining there's more swelling on her legs, more on one leg than the other. She's not tolerating her exercises routine. The physician, again, just focuses on the weight. You need to, eat less. I don't know about your swelling. That's something that I don't deal with. Maybe you should talk to your PCP about that. The trainee that was with the attending at that time, as they're walking out, it just sounds like, this person is fat and lazy and they don't want to put in the work, and I wouldn't operate on that person, right? She hears that, nonetheless, continues, goes to the PCP. PCP agrees with orthopedics. He needs to lose weight, again recommends, but no further workup is suggested. Okay. Comes again for the third visit. At that point, okay, she's here for a third time. Let's see what's going on. Let me wait and stop and reassess what's going on here. Have you been worked up for this? Have you gone to an endocrinologist? Do you know why you've been working? No, I've had these issues for a long time. The pain in my leg is really concerning. And then sends her to endocrinology, sends her for an ultrasound, looking for DVTs and other things. Turns out later on that week, the patient develops significant right-sided chest pain, shortness of breath. She's taken to the emergency room via ambulance. The ED physician asks her about, any shortness of breath lately, which she agrees to. She's not using, she's not tolerating her regular exercise routine. She also mentions that she's had, her sisters have had blood clots. One was pregnant earlier in the year and had a DVT. She's had some issues with weight problems and other medical problems throughout the years. Ends up getting a CT, has a DVT and a PE. Other labs and tests during her admission shows that he's hyperthyroidism. She has an autoimmune syndrome and hypercoagulability. Okay, so think about all the different types of biases that are presented here and how that affected this patient's care. Okay, so she had chronic knee pain, obese, Hispanic, third opinion. Already a lot of us are like, oh my goodness, third opinion. Why did she need 3 opinions for this? Well, you know, obese, Hispanic, we're already making our own biases about this patient. All right. The medical staff caring for her had attribution bias. Her BMI is 35. That means she's probably not exercising. She's not eating well. And probably all her other symptoms is because of her weight. That's anchoring bias, right? She also feels disrespected. She omitted important clinical information that could probably mitigate some of that confirmation that all of this is related to her and is her own doing, okay? So in terms of her patient outcome, a massive PE could have probably taken this child's life. She went to at least 4 different physicians, 4 different visits, and never had a proper workup, okay? So again, all of these things are important for that. We have another example here. This is an 8-year-old African-American child. He's coming with spastic diplegic cerebral palsy. He comes from the islands, an evaluation to help him walk better. So this child was initially walking. He's no longer able to stand, has significant crouch gait. The first visit, mom comes, she hands a flyer, asking, help me and our journey to help my child get better. Also, she's asked for snacks. She said she literally just came from the airport. She's very hungry. We provide her with food. We ask about different things. There's a lot of social factors that are coming in. She's not able to get the care that she needs to in the islands. And she finally was able to come to the US, to mainland. She's in the US Virgin Islands to get properly evaluated. We evaluate the child. He has significant contractures. He needs to have definitely therapies and different braces and things that are not available for her there. And so we talk about what they need and how we can help them obtain these things and see if they're able to come in a few months to see if we can further coordinate this. They don't come for 18 months. The situation has not gotten better. She's tried everything. She was able to get some donated equipment, but it still was not enough. Again, the patient is, asking for donations from the staff members, which we all, think is very odd, right? And so we eventually we set up for a third visit where we discuss possible surgical intervention. And since she's not able to get the care over there, we are going to provide a 6-week intensive therapy here and see if that helps the patient. So eventually he's able to come, we're seeing her, the surgery is discussed extensively, and the time comes for her to have her surgery. Post-operatively, after she's discharged, she missed her therapy appointments. She had concerns with poor pain control. She had called multiple times throughout that first week until he had the first post-operative visit. And as she comes in for that first initial post-operative visit, the staff comes in. These island patients are so needy. They've been calling. It's nonstop. And you want to see what's going on. So it turns out mom breaks down. She is actually in a hotel room. She had to come with her 4 other children because she couldn't leave them with anybody else. They brought only enough, financial support to eat. So she didn't know she had to pay transportation to come to the visit. So that's why she didn't come. When she was in the hospital, he was comfortable and was told just to take Tylenol and was never given the proper pain protocol because he was doing well just with regular Tylenol. And so there was a lot of things and a lot of issues that were misinterpreted, and that affected how this child was doing. So we recognized his bias. We spoke with the staff. We spoke with the parents. We were able to get, donations to help them get the care that they needed. We were able to provide a therapy that was closer to where they were staying. And literally the child is able to stand and is given their first steps that they haven't done since they were 1. And so it's really important to recognize your biases, to point them out, to speak up and be an example. So examine your own biases. There are a lot of us are unaware of what they are. We want to make sure that we are, you have different levels of this. The ways that I do is individualize. Don't group people into groups. enrich their communication, share your experiences with diverse patients, and repeat that cycle. Be aware, mitigate, and self-check-in. How can I fight it? Point it out, speak up, and be an example. Thank you.
Thank you, Dr. Payeris. That was awesome. Dr. Suleiman, excellent. I am Dr. Taylor, Erica Taylor. Pleased to see that many of you who registered and are spending your Monday evening with us are our colleagues and our trainees and our mentees. I'm going to wrap up this session, and I know we're really anxious to get to the Q&A portion by holistically giving an idea of potential strategies for success. Now, admittedly, this is a misnomer to the presentation. I will argue consistently there is no one strategy, there is no one solution, but hopefully by the end of the next few minutes, you'll have a bit of a framework for your own organization, department, division, environment that will help you incorporate the background of implicit bias that Dr. Suleiman talked about, strategies to mitigate it, the in-depth analysis and classification of biases Dr. Payeris presented into your day-to-day activities, and quite frankly, into your leadership structure. So a few things that I want to really acknowledge when we talk about implicit bias. Rarely in an organization or in an orthopedic department is the sole goal combat implicit bias. Generally, it's part of a greater mission statement, a greater strategy, a greater attempt at rebranding or redefining oneself. But when you do this work, it's important to acknowledge that it is the constellation of experiences that inform us of the decisions we make and the paths we pursue. Now, as I said before, each individual will have their own framework of the environment. And quite frankly, your lens and priorities can change over time. Now, much of what I just mentioned, we cannot manipulate, we cannot change, nor should we. And then lastly, but importantly, there is power and opportunity. And so what you're seeing in the themes, whether we're talking about recruitment, retention, promotion, patient care, is the power of affording opportunity. And that's where we put those together to lean into action. So many of you asked, what do we do? What's the first step? How do we move forward? And I hesitate to use the language such as step 1, step 2, step 3. So what I've done is really broken this into different parts. And for the sake of time, we'll just focus on 3 parts. Part number 1, which I appreciate Dr. Suleiman for including this in her slides, is to slow down and set the foundation, really create a shared vision. What is the goal? When you're on this mission, when you are addressing these issues, what is the goal? And it actually might vary, and it's important to create that shared vision. So for example, in your organization or in your department, the goal might be, you might have seen this written on the statement, is to eliminate racial health disparities. So you have to really know what that means. That's focused on the patient. It's focused on morbidity, mortality, disease processes. Why? Well, there's a growing body of evidence demonstrating that, in particular, minority populations suffer from earlier onset of illnesses, a higher level of comorbidity and impairment throughout life course, increased mortality rates. And the consequence of this is not just limited to the marginalized group, it actually impacts all of us. You can see it not only in the form of stress or mental impact, but also in economic losses. And as we're seeing even now in the COVID-19 pandemic, overall distrust of medical systems and compromised care. On another note, the goal of the organization or department might be, well, let's address social determinants of health. Many of you have seen that language several times, but what does that really mean? So this is one of my favorite images from the Kaiser Family Foundation that explains those 6 broad buckets of social determinants of health, or factors that are related through literature, through evidence, to health outcomes. So if you see on the far right of your screen, healthcare system is really just 1/6 of this. What we're looking at is economic stability, neighborhood and physical environment, education, food security, and importantly, community and social context. So what does that mean? Well, look at the first one, social integration. That hones into historical and current contexts in which different groups found themselves represented in our country, in what types of jobs, in what types of obstacles, in what types of oppression. All those together, when we reference social determinants of health as the goal, and then talk about implicit biases to mitigate that, these are the things we're referring to. Okay, let's go a little bit more traditional. Perhaps the goal is we really want to eliminate underrepresentation in medical school. So Dr. Suleiman touched a little bit about medical students. And so this is honing in onto what many of us coin pipeline programs. How do we increase representation in medical training by addressing biases in recruitment? Well, it's interesting. You know, I appreciated the reference to the earlier 20th century as if we have come very far, but quite frankly, this is a more recent study that shows we have not. The data point they used here is the RQ, representation quotient. So as you can imagine, what they did was they took a certain population, in this case, matriculants into the US medical schools, and compared it to its matched population in the United States. So as you can infer, an RQ of 1 means that that particular group is equally represented in the medical school as it is in the country. A score above 1 is deemed overrepresentation. Score below 1 is underrepresentation. So if you look at the 17 years of data here, between 01 and 2017, the little dots that represent underrepresented minorities may have blips up and down, but stay consistently underrepresented. If you look at white females and white males, and these are matriculants, if you dive deeper into the study, they also looked at applicants, the numbers are very similar. So we really haven't moved the needle that much, if at all. Okay, so let's go a little further. Maybe the goal is let's address biases in residency training. That sounds a bit more focused, a little easier to flesh out, particularly with the help of the ACGME. So this is an interesting study because you really need to dive deep into what you mean by eliminating or addressing biases. This is an interesting study from just last year that looked at reported biases, in this case, internal medicine residents, from patients. So we often don't talk about that. We often are looking interpersonally inside our own environment and in our interactions with each other. But this is the percent of participants broken down on your left-hand side by ethnicity, on the right-hand side by gender, relative to the majority in terms of who's experiencing biased patient behavior and what types. Now you can see the data for yourself, but what was most disappointing in this article was that over 80% of these respondents who had experienced bias never reported it. So we're not just talking about identifying biases. We're not just talking about classifying them. We're talking about creating a culture where there's safety and security and having them spoken about and discussed and then addressed. Okay, let's go one more step further. Now let's talk about a goal that might be eliminate inequities in academic medicine. So now we're acknowledging that it's not just at the patient level, it's not just at the social level, it's not at the medical school or even just the training level, it actually is amongst our faculty. So I won't read these boxes to you. I suspect this is not new to you, but this is how biases can show up in different places along the entire course of what we do when we are practicing orthopedic surgery. And so in conclusion for part 1, the strategy really is focused on setting the foundation. It is important to solidify your mission agreement. We'll go further in a minute as to why that's essential. But you have to balance aspiration. So sometimes using the word eliminate really sets you up for disappointment and failure if you don't eradicate every instance of racism, sexism, homophobia existing in your culture. But also really create that agreement amongst all your teammates and parties. Define the goal. So understand the terminology. Don't just use buzzwords. Understand what it is we're talking about and why we're talking about it. Dr. Suleiman, Dr. Payeris did a fantastic job giving you that language, and I hope you use it. And then lastly, for this part, consider instruction in crucial conversations. Now, for those of us who are privileged to work at academic medical centers, there's a plethora of faculty development opportunities considered crucial conversation education, not just reserved for those of us who need a little nudge in the right direction, but really open to all of us. And that's where you learn how to optimize dialogue on implicit bias topics. There's an art to that. And so that's what I would contest would be your first steps, if you will, for part 1 of strategies for success Now, part 2 is actually quite fun if you really want to dive deeper, and that's evaluating your organization dynamics. So understanding the DEI structure in which you work. Now, here's just an example. Some of you can relate, maybe some of you cannot, but let's take the typical academic medical center. Now, in general, unless you've reached the wonderful achievement of integration across the board that many of us talk about, you may have different entities that impact the health experience. So let's start with a university where, in general, there's a president. Their DEI leader may be called a chief diversity officer or a director, typically of a center or an institute. The structure could be a formal center or an office, and the focus is on staff, students, and faculty. So let's go over down to the hospital, or to the hospitals plural, the health system. The entity leader could be a CEO, maybe it's a chancellor. Sometimes really rare to find a DEI leader formally appointed in that section. The structure is typically work groups. That's where you might find population health, community health, terms like that. Focuses on the consumers and the employees, and for the most part. Then there might be a physician organization where entity leader is a president. Again, rare to have a DEI formal leader in that particular entity. The structure is usually in the form of a committee. Focus again, consumers, health providers, and employees. And then lastly, the School of Medicine. Entity leaders are typically coined a dean. There's typically, not always, a chief diversity officer. The structure can be very flexible, very agile, can evolve over time, and usually is a council or a series of work groups. The focus is on the faculty and trainees. So looking at this in a classic academic medical center, you can already see there's some current obstacles that need to be addressed or acknowledged when you talk about implicit bias mitigation. There are multiple stakeholders represented across entities. There's no clear accountability pattern. There might be redundancy of efforts, and that leads to this slide on identified barriers. So again, I won't read these all to you because I suspect they're very familiar. No formalized coordination, redundancy of efforts and offerings. And then what is also common is an emphasis on interpersonal racism and sexism. So we're very focused, very comfortable talking of how you and I interact, how the two of them interact, how you interact with the patient, interpersonal racism, interpersonal sexism, how to combat that, but missing the holistic picture of where we're trying to go. Where is the movement going? Why are we here? Why are we doing that? So really setting a broader context in the work. So again, in summary, for part 2, it's really important to perform regular environmental assessments. Now be very thoughtful and practical when you do this. This is not the same as asking your female colleague or your Black colleague, what can we do better? How do you feel? How did today's news story impact you? This has to be done in a very sincere way, in a very creative way at times, whether it's focus groups, surveys, or anonymous feedback, to really determine where you're starting from. And quite frankly, in my experience, you're always starting from a different level than you would assume. Restructuring resources. Now, this can take some work because you do need to garner engagement, but consolidating your resources and emphasizing cross-specialty or cross-entity teamwork. And then importantly, distributing the accountability. So including leadership and individual practitioners with diversity, equity, inclusion metrics. This is easier said than done, but there are examples of places that have done this well. And so that wraps up part 2. And then lastly, as I close part 3, really diversifying your toolbox. So thinking outside of the orthopedic sector. Now, I know for much of what we do, we tend to like to learn from each other. Dr. Payeris mentioned the concept of groupthink, for example. So if we're relatively stagnated, perhaps it's time that we think outside the box. Here's an example. So many of your institutions probably implemented this. I know where I am at Duke, this was implemented in 2017 and 2018. This is from the AAMC. So I had mentioned environmental assessment earlier. This is a 22-question survey that is distinguished from the culture and climate engagement surveys that hones in on how to determine whether your academic medical center is responding well or still has opportunity in the diversity of its community. Now, I listed the 8 buckets that the questions, which are very well and thoughtfully done, address, from common purpose to trust, to cultural competency, to respect. This is one tool to explore. You are more than welcome to pull from it, personalize it, and institute it where appropriate in your place of work and care. This is also a different type of way to introduce microaggressions and implicit biases to your groups. This is available for free online. It's something that we instituted at the Fuqua School of Business in one of our leadership classes. And it's a choose your own adventure. This one's titled Killing Me Softly. Now, the goal of the game, as you can read here, is to illustrate what effects accumulations of microaggressions can have physically and mentally over time. You start by choosing one of two characters, and because this is created more in a corporate space, these two individual characters are not going to clinic, they're going to work in a new job. But the principles are the same. And as you go through the game, the choices are not linear. What you choose to do in response to microaggressions determines what choices you have later on. And sometimes if your stress level is high, your choices of action are lower. So here's just a little snippet. I don't want to ruin the ending or any spoilers in case you decide to pursue this game on your own. But let's take this one character. In this choice, I chose Leslie, who is an African-American female, who's starting her first day of work. She's walking around with her supervisor, goes to her cubicle, and a colleague leans in and says, "Where are you from?" Now, just for the purposes of tonight, I chose the last answer. My family has been in New Jersey as long as I can remember. The response from the colleague is, "That is so weird. You look so exotic." Her response is think, and then it continues. But as you can see, it gets worse and worse. The stress accumulates, and that's just an example of a different tool, in addition to the IAT, that you can use to segue or guide the conversation about microaggressions. References. So we love peer review, but there are actually some textbooks outside of orthopedics that can be very helpful. For example, Dr. Tweedy, who just happens to also be at my institution, wrote this book that many of you heard about years ago. It's actually spearheaded to multiple movements across the country called Black Man in a White Coat, a doctor's reflections on race and medicine, to give more personal context. When COVID-19 first began really impacting how we changed our styles as diversity leaders, the Inclusive Excellence Leadership Academy published this free online ebook about a DEI crisis action strategy guide. Scott Page, a few years ago, I had the pleasure of meeting him, is an economist at the University of Michigan who published The Diversity Bonus, one of my favorite books. I believe I read it in just one day, that talks about the economic bonus of having diverse teams when addressing complex problems. Now, I mention these resources not because you already don't know everything about this, but because hearing different voices gives you different language that you can use in different groups to get different results. And sometimes it's important to have a different way of speaking about these topics with different groups in order to have a greater impact. And then, of course, one of the tried and true books, Strategic Diversity Leadership by Dr. David Williams, is important to have at least on your shelf, if not for a quick reference at times, to understand how do we do this work better. And this is actually bent towards higher education, so very relevant to our orthopedic education curricula. And then lastly, best practices, networks. We use networks for just about everything, but are we using them optimally to talk about implicit bias, to talk about DE and I initiatives? One possible untapped network is your external faculty colleagues. So thinking outside of your institution, reserving judgment, reserving pride, and going outside to say, hey, we need a little bit of help or guidance or something new. What are you doing? There's affinity organizations. There's multiple societies within the AAOS. All of us on this panel are part of many of them. There's specialty societies. There's non-medical societies you might be a part of that are still doing this work. So have you tapped them? Have you networked with them? It's okay to not have it be your own idea. The time is too urgent, too pressing for us to wait for our own innovations. Internal student and resident councils. This is actually one that's mostly unused by my faculty colleagues. You likely have some type of student group, whether it's the SNMA, AMWA, the Latino Association, or a resident council, typically coined at most institutions a minority house staff council, that is having an implicit bias webinar or an implicit bias panel. Now, often they don't select orthopedic surgeons to sit on them. I've been fortunate to be asked to sit on probably a dozen in my life, but this is a resource where if you want to know how you could do it better, what are solutions in your own environment that you can lean on. And then lastly, external health systems. Again, we do a lot of work with other health systems who really want to know how to lead in these efforts, and it's okay to ask them for advice and really to pioneer and network with them. And of course, I'd be remiss without mentioning at least 50% of us on the panel tonight are part of the Orthopedic Diversity Leadership Consortium, which is a newer network created just in the last 5 months of diversity leaders across the country who come together generally in one-on-one fashions or in group sessions to solicit advice on how to create strategies for success in their own environments. And like I said, every environment is different. We've even had biotech companies reach out to us for assistance. So the need is real. And of course, membership's free. So here's a website if you'd like to visit it. And so as I wrap up, again, part 3, using other resources outside of orthopedics, such as business education, within medicine, some of the non-orthopedic specialties as your part of your toolbox. And then we always talk about experiential learning. So trial and error learning, really resisting retreating. Instead, modify and try again. And I have to mention my newest addition to the family, my 3-year-old Lauren, who the other day played this game with colorful popsicle sticks with me. The 3-year-old mind is amazing. She came up and she said, okay, mommy, what you have to do is close your eyes, pick a popsicle stick, and here's the twist, and guess the color. If you guess the color wrong, you win. Okay, love 3-year-olds. And I said to her, Lauren, what do you do if you guess the color wrong? Do you lose? And she said, no, you don't lose, you just try again. And it resonated with me because I believe when we talk about DE&I, implicit bias, we often think if we don't win right off the bat, we've lost. And I would contest that that is the wrong attitude. Retreat is not helpful. We need allies. We need everyone really at the table on this webinar, at the discussion. So instead, modify and try again. So take home points. My email address is at the top. Implicit bias in orthopedic surgery has esoteric roots in its challenges. We are very unique in some regards. But the strategies for success incorporate foundational agreement, that was part 1, organizational restructure, part 2, and diversification of resources, part 3. Each department, organization, individual has its own unique set of challenges and will vary in response to initiatives. And like Dr. Pieri said, always at the end of whatever process you choose, repeat, reiterate, and let's just keep getting better.
Awesome. Thank you. Thank you all for the wonderful talks. We have a fantastic panel on today. Again, feel free to submit questions. We have a few minutes now. We're running a little bit late, but we do have some time for questions. I'll start with one from the chat box. Is my practice in the process of evaluating physician burnout? There's a very small proportion of female physicians in our MSK group. I've been assigned to the committee to help improve the utility of the survey. The discussion has been how to incorporate more specific feedback from female participants with a plan to conduct individual interviews. Is there a better approach here? So me personally, I actually really enjoy doing focus groups. I think there's more strength in numbers than simple surveys. So if there's a very small group that you're trying to get feedback from, when you have individual interviews with that leadership, it's hard to really be honest and feel empowered to be honest on your experiences. So personally, I like to have a focus group where you try to get a group of these female participants. You ask these questions in person, you get the reactions than just filling out a survey, but you conduct the focus interviews with a third party. So somebody who is not in your department, somebody who's not in your leadership structure, where then they provide you with that honest report instead of just a simple feedback. Anything else, Erica or Monica, to add?
I would agree with you, Dr. Sullivan. I think when you are struggling with privacy, you know, I mentioned this in the talk, creating an environment of safety and security is above all important. Many don't believe this, but retaliation can still happen even today. And so the focus group by a third party, which may require some financial backing from the institution, is one way to get around this. And they're actually a lot of individuals who are skilled at having these thoughtful, sensitive conversations. The other thing to actually understand is you may think you know what the group is going to respond with and they'll be easily identifiable, but we've done several surveys in our department in our health system where a lot of the DEI negative responses actually came from majority groups. Feelings of being devalued or being overlooked for opportunity did not always come from the marginalized group. So that's just something to know, is that they may not have identifiable answers the way you think they do, and not to just assume that we're all monolithic folks. I think having the focus group is a great idea, but also maybe having a little bit of a test of the questions you're asking, they might actually be applicable to everyone.
Okay, there's some questions that were submitted ahead of time that I wanted to make sure that we answered. How do we successfully report instances of bias?
I mean, I think, you know, personally, it depends on where you're working and what your institution and what you have. And, you know, you may or not be lucky to have already a DEI group, you know, program in your institution. So it may be a little bit trickier. So you have to go to your supervisor, your practice manager, your chief, who can bring this up. You know, we all experience some sort of bias in what we do. And sometimes we may not know who to go to. So who do you speak up to, right? And so, I mean, I can share just, you know, personal instances where, you know, I started my attendantship at the same day as one of my co-fellows. So we literally started the same day. He's a tall, white male. We went to the same program. We trained at the same place, started the same day, and our experiences starting a practice were completely different. And, you know, people were completely unaware of this. And this comes from the person setting up your OR to setting up your cases to, you know, all the way as high as, you know, who's giving you your academic appointment, right? So who are you? And they don't know you, and why the people are usually not aware that this is happening. So just talk to them, bring it up to them. He wasn't even aware that I was treated differently. So, you know, you can start with your partners and see get a feel like, am I feeling this differently? Because then we also have our bias that, are we getting picked on all the time? Am I making this up, or is this like real or not? And so, you know, I think talking to your partners initially, depending on what your situation is, talking to your chief, you know, sometimes, you know, you want to see if you have, who are your advocates that are going to help you spread the, you know, who are going to be your allies? Who's going to help you spread the word? Who's going to help you get to where you need to be and escalate as you need? But again, I think, and then eventually, if you want to take on the challenge, which I'm currently working on, creating that DEI program within your institution, and how we can bring those resources, or, you know, guidance to other resources. I think that's another important aspect that we can all sort of put a little grain of salt.
Yeah, I think, well, Monica, the other point that she makes is that it really depends on what institution little structure looks like. So for me, if you're at an academic institution, you're training residents, you have a large GME office, you have to have some sort of reporting mechanism. And it has to be separate from your typical, most ACGME requires that GME programs have some sort of reporting mechanism that's anonymous, but you have to separate out bias. So what we created was a bias reduction task force. So this faculty, residents, and to students across all GME programs. And so the button is on the website, you submit, all we ask is identify what department this is coming from, because we get a large number from across all specialties. But it breaks away, if I am experiencing something within my department and I want to remain anonymous, you know, it's hard to, because I'm the Black woman in the department, it's hard to hide that. And so it gives you a level of protection. So if those that are submitted anonymously, we review monthly, and then we have a biased grand rounds. So it's a grand rounds format every 4 months where we put these high level cases that occur, and we have these discussion panels, and we break down decision-making processes, so that when this happens again, the initial shock is what gets people, and that's why you're silent at the beginning. So it happens, you're like, oh my God, I don't know what to say. So it's almost like desensitizing you to what these biases are, so you could have the opportunities to speak up in those moments. We had another question, any suggestions for how to mitigate implicit bias in resident selection in addition to the IAT?
So I can comment on that. So many different ways you can go with that question. There are definitely pre-readings, videos people can watch ahead of time, but the accountability is missing. And so one way is to actually, in preparation for the interview process or even the screening, have some set examples of, here's an application that for their leadership experience should be given the top score when you go through the screen. Here's an example of what we will rate a 3 or a 2, and give some sort of standardization of what types of gestalt people should use. Because that, regardless of what type of format you have, people will still rely on what they think the leadership or the overall culture want in their program. That's not an overnight fix. It's something we're working within until we can really see longitudinal change. Another thing to do is to incorporate diversity into your interview application questions. So we do that on interview day. There's a room that I typically staff, and then there's a counterpart with the other half of the applicants about leadership, teamwork, and diversity. And it's really asking standard questions about experiences working with heterogeneous teams as peers. So not just talking about serving in a medical student-run clinic, a different population, but working alongside others who were different, whether they were different in ideals, upbringing, ethnicity, gender, whatever it is. Do you have experience in that, and what did you take from it? And in that conversation, you have a chance to really implore upon the applicant what your institution and division and department stands by, what your plans are. I think a lot of us saw in this recent application cycle, many applicants are asking, what are you doing about it? What is your department doing to mitigate racism and sexism and all the other things that have been plaguing us for many generations? This will be one way to, as I said before, truly integrate DEI into your everyday experiences. And so that's just a few examples. There's many more, but it really depends on the structure you have, the training you have, how many times you've had conversations about that, and then who's on the selection committee. Are they well versed to have those discussions?
In addition to that, as far as selection, do you have diversity of people's eyes? Who's looking at these applications? Is it just the program director? What I found, we eliminated step 1 2 years ago from all GME programs. So you cannot look at someone step 1 applying to our program. So the first question when my office eliminated it from our institution was, well, what do you want me to do with these 800 applications? I have no screening process. And so what we did was increase the number of people reviewing those applications. So instead of having 3 people reviewing all 600, we had 12 committee members, and each committee member reviewed two reviewers reviewed the same application. And then we looked at the scores. If we're seeing dichotomy in scores, it was usually between 2 very different people on the selection committee. And so you have to have different eyes looking at the application, because when we look at the application, we say, okay, why do these 2 individuals, me, a Black woman, and my white male colleague, have 2 different scores for this applicant? It opens up discussion to see beyond what I'm seeing, and then I could see what he's seeing. And it opens up discussion to really make sure that we have this diverse selection process. And then actually setting metrics. So if I'm getting 22% of female applicants, am I interviewing 22% of those total applicants? Am I interviewing 15% of your applicants? Whatever it may be, you have to set that metric for yourself. And if you go through your review process and you see there's clearly a hole here, there has to be a way to go back and look at the selection again. I think we have time for maybe 1 or 2 more questions, but go ahead, Monica.
Yeah, I think you have to diversify who is choosing, right? So you have to get on that table. That's what I've been trying to do. To get on that table so you can have an opinion, you can bring in the diversity, and you can see that new set of eyes. So if the selection committee, that you want that to sort of represent what you want your group to look like, right? So then you sort of, if you're sitting at those tables, invite people that look differently than you, because that is really how we're gonna be changing the culture. And then I think that will be a better selection process in that sense.
And I think, this is a great question. Even when you're creating the rank list, and I don't know if every institution has it, but often there's a discussion when you have your top, 30 and everyone wants to talk about it. What can happen, and be cognizant of this, is you might find yourself comparing applicants from similar groups to each other. So I've witnessed this before. I've been to many institutions, so don't try to guess where I was. Where it was, so Elizabeth has these accolades, but Jennifer has these. Out of the two, which ones do you all like best? And then maybe they'll say Jennifer. Okay, so they'll put Jennifer high, and then they'll move on to the regular applicants. Same thing might happen from the beginning. We want more diversity in our training program, so we need to have at least one Black applicant or one female applicant match. Now, that mindset of there can only be one, whether it's 1 out of 5, 1 out of 6, 1 out of 8, will for sure commit yourself to a very homogenous group. Because what you're saying is the opposite, the extreme on the other end of having an all-female class or an all underrepresented class is so far gone. We would never focus on that. So let's temper baby steps. And so the concept of waiting and taking little tiny increments is really doing a disadvantage. The other thing, the other misstep is to assume that that one female or that one underrepresented minority applicant is only desired by you. And you are the only institution weighing in on whether or not they'll become an orthopedic surgeon. And so it's a cultural, traditional mindset that having these discussions like we're having tonight, again, warms my heart because I think we're breaking them down slowly by having the safety and the support and the allyship to discuss it openly, because in the past, this was something that was kept just to ourselves.
We had one question that was actually submitted by multiple people, but how do we move this entire conversation to leadership and the gatekeepers of the largest practices to care about this issue? So how do we move this conversation to the institutional level, the departmental chair level?
So I'll give you, one example that we're working on. So if you remember that organizational structure slide I showed, the two entities in the middle, whether it's your health system or physician organization, really sort of the highest of the high levels, including chairs and others, typically, until maybe recently, didn't have a designated DI leader. But when they do, or when there's intention behind putting some accountability behind it, one way to hold people sort of to task is to integrate DEI, KPI, key performance indicators and metrics into their job descriptions. So for example, we just are rolling that out at Duke Health. Our clinical medical directors will now have accountability metrics that are not just CG caps, not just access-based, not just value-based, healthcare-based, but also incorporating, have you done your, implicit bias training as the medical director of the clinic? How many A3s or QI projects have you done that address health disparities? How many times have you received a bias complaint in your clinic, et cetera, et cetera? Now, every environment requires different KPIs, but integrating it into job descriptions intentionally and vocally is one way to hold people accountable. But one thing I will caution is on the other end, you need to resource someone to field those reports. You can have the metrics, but if you don't have someone who has the protected time, the administrative support, the resources to take in that information, because it can get heavy over time, then those reports will just sit and nothing will happen. And so that's why we really advocate for institutions to rise to the challenge, not just of addressing or acknowledging these issues, but putting financial and administrative and organizational resources behind it to have appropriate people in place to take the reins when it comes up.
I think it's an important concept, and I'm not lucky that I am in a big academic institution that have some of that support. I'm in a community hospital. We do have residents that come from different local medical schools, but we're not really affiliated with any. So how do I do to create that? Like, are there any grants that I can do to assess that? Now that diversity it's cool and popular and everybody's talking about it, which is great for us. We have to sort of get that ball rolling and keep with it. So, personally, what can I say? Okay, you speak to your chairs, you speak in committees, get involved in the hospital committees, okay? finally got into the medical executive committee. We need to start a task force. So start with like a small group, because I don't have anything, I don't have the funding. So at least getting initially on those conversations and getting maybe some local support, and then start kicking off those programs, kicking off some surveys, and have one or two people that may be able to share some of that and help you. Because a lot of times, like I said, some of us may not have all that, structural support or financial support. But, again, we don't give up. We keep trying and we keep doing it at our own paces, as long as that conversation.
And lastly, I would say from a leadership, institutional, hospital level, at the end of the day, money talks, right? And so I'll give you an example, we had this phenomenal resident in one of the other departments who was just absolutely phenomenal, did a lot of work in D&I initiatives at our institution. Everyone from the institutional level who had worked with this individual wanted this person recruited. And their division said, there's no space. And their entire division were white females. And this Black woman, who's been an all-star candidate, chief resident, there was no room. And so we made the case similar by looking at my own practice. So my practice is 65% people of color, Black and brown communities of Chicago who are getting joint replacements. And so what I asked as a sample for my own department was to see how many patients were we doing joint replacements on from these underrepresented backgrounds prior to my start, and what have we looked at the trajectory in my 3 years here. And to see a 20% increase in Black and brown patients getting joint replacements, specifically from my practice, speaks on volume, speaks on how much money the institution is bringing in, and what the impact of these URM faculty are having, not only on just taking care of our patients, but the financial impact. And so you have to show, and institutions have to look at why do we need this specific member? Why do we need to recruit our Black and brown residents, our female residents into these institutions? I think we have time for maybe one more question from Dr. Levine. Dr. Taylor, your last point is well taken about trying again, but what happens if people are too scared to even try and engage if they say the wrong thing?
Dr. Levine, good to see you virtually. Thank you for all of your wonderful comments and questions. That's a very common fear, hesitancy source, thought to consider. One way, there's actually a multitude of different models for how to practice having a conversation about bias. So let's say you made a comment, it was not received the way that it was intended, it had a different impact. There's actually, almost similar to the SBAR format, something you can do to engage a productive dialogue. But it all starts with first acknowledge that the other person's impact was real. Another thing that you can do, though, if you have a fear of saying something or saying the wrong thing, practice on someone that you know. And it does not have to be the person of a different group. It could be someone who is very similar to you, but pull them inside. Hey, I'm going to have this conversation. Can I practice off of you? Now, in an ideal scenario, you would pick someone, either someone in this panel, someone on any of the other, dozens of panels that have been done, to say, hey, can I run this by you? Can I say this, what I'm going to say, and practice saying the words. It's not often only the fear of the response, but it's discomfort with saying these words, because we usually did not. I actually advise people, before you ask your one Black faculty member or your one female resident how they feel of recent events or initiatives, understand that for many, many years, no one talked about this. And so give some grace, and it will be given to you, to understand this is a very nuanced conversation. And so also the response you get is not necessarily the response that will last for the next 10 years. You may ask someone the next day the same question and get a different response. So that's where you have to be repetitive, reiterate, understand that this is not a one-minded, single thinking environment we're in. And so diversify who you're running these conversations by. Now, if you happen to say the wrong thing, if you use some of the models I mentioned and acknowledge the impact, do not deny, do not do any of those things that Dr. Suleiman listed in terms of mitigating or missteps and bias. but then work in a productive dialogue to continue the conversation, even pulling in a colleague if you feel like you need some additional support, then that's how you make progress. I think the whole point of tonight was that this is not a perfect strategy conglomeration. There are definitely rooms for imperfection. And so that's why I would say, you know, the bravery, the courage has to occur on both ends in that regard.
There's one last question that was submitted. I think we have time for a quick response. What can we do to not have the next Black resident judged by the last Black resident, by the past or last one, good or bad? The majority of residents are not judged this way. You know, so I've seen this time and time again where we may have a poor performing resident of color or a poor performing female resident who, you know, the next election year ranking comes along and we're constantly referring to, oh, you know, she'll be problematic, he'll be problematic. And we never really have those conversations with the majority. And so it really takes into attention by calling that out. That behavior happens a lot, but we really need the faculty in these meetings to really call it out that we can't judge this Black resident based off the last one. And it's really easy to do so because we see those stereotypes, we see that similarity, whether physically, having the same skin color or gender, but it really cannot happen.
I think another important point, and I think this sort of hit home recently, is why are they failing? Why did that previous resident fail, right? We already know that it's a little bit difficult, and the path to getting here and sitting in front of us talking about these things is very different from each other, very different from the white male, right? So why are they failing, and how can we do, and what can we set in place for them not to fail? And because, like I said, Dr. Levine just put there's never been a white male resident, right? But we address different things in different ways. So I think, you know, programs and identifying why are they failing and provide the support there can keep us retain those residents, address those issues, and hopefully take away some of those biases for the future. But I think it's definitely very real. And if you keep having that one person every 5 years, and it was a bad one, then you're gonna jinx it, or, you know, ruin it for the next one. So again, don't individualize and don't group together. And all residents should be treated equally and given the same opportunities. And any failing residents or struggling residents should be helped.
And it's because of that reason that most of us, the Black women, the Black males, the females, we feel that we have to be twice as good just to be seen as the same. And that pressure of waking up every morning, even you can't have a bad day. You're told you can't have a bad day because of the judgment that you feel that you will experience and who will come after you because of the choices that you make and the performance that you are. So just understand that the pressures that some of our URM, our female residents, are undergoing on a day-to-day basis just to be seen as the same, because we fear this judgment. And with that, I think we will close the webinar. I will turn it over to Dr. Laporte. I want to thank everyone for being here with us tonight and thank all our panelists.
Thank you, Dr. Suleiman, Payaris, and Taylor, so much for your outstanding talks and for sharing your stories and resources and strategies. This was phenomenal. I hope that people will take some of these lessons back to their programs and continue these discussions moving forward. I invite you all to join us at the RJOS annual meeting, which hopefully will be in August, which is being co-chaired by Dr. Suleiman. And thank you. I can't thank you enough. This was outstanding. And yeah, this was recorded and we will post it hopefully later this week. Thank you all.
Have a good night.